Hello everybody, my name is Angela Dulhunty and I'm going to be presenting this talk on the 2328S mutation. Before I start, I'd like to thank the organisers and the Journal of General Physiology for having put together this amazing meeting. And thank you very much for inviting me to talk. The work that I'm going to talk about is all done in collaboration with Samantha Salvage, James Fraser and Chris Wang from Cambridge. The mutation was first described in 1999 as associated with CPVT and atrial fibrillation in structurally normal hearts. Chris Wang and his colleagues developed the mouse model, and it had an increased incidence of arrhythmia. Calcium transients are shown here, paced under normal conditions in the wild type, very regular responses to pacing. In the mutant, there's some spontaneous events. In the presence of isoproterenol, spontaneous events appeared in the wild type, just a few, but in the mutant, almost every event was spontaneous, apart from the first response. In atrial myocytes, the action potential was examined and duration and refractory period were normal, but there are an increased number of delayed after depolarizations and severely disrupted diastolic calcium release, which is shown here. Again, calcium transients under controlled conditions, a few spontaneous events after addition of isoproterenol, some quite prolonged spontaneous release events in the mutant in the absence of isoproterenol, and a huge calcium release event shown here in the presence of the drug. This is consistent with the idea that diastolic calcium release is enhanced because of release through the mutant ryanodine receptor. This increases sodium calcium exchange and depolarization, which leads to triggered activity. And this is where I came into the story, because we were interested to see what happened to the mutant ryanodine receptor channel. So these are single channel records from a wild type and a mutant ryanodine receptor with 1 micromolar cytoplasmic calcium and 1 millimolar. This is in the end diastolic range. And you can see that with this calcium concentration, there's significantly more activity in the mutant than there is in the wild type. And this is 1 millimolar cytoplasmic calcium, which isn't physiological, but we included it to fully define the calcium activation curve, and not much difference here. The significance of the potential is that at minus 40 millivolts, currents flowing from the luminal side of the channel to the cytoplasmic side of the channel, which is the physiological direction. At plus 40 millivolts, it's flowing in the opposite direction. In general, we recorded both potentials, and in general, there was no difference or very little difference between plus and minus 40 millivolts. So both data from both potentials was included in the average data. The average data is shown here for open probability at 1 micromolar, 1 millimolar cytoplasmic calcium. And you can see that there's a significant increase in open probability in the mutant, a significant increase in the mean open time, and a significant decline in the closed time. If we looked at the calcium activation curve, it's essentially typical for a cardiac ryanodine receptor in the wild type channels. In the mutant channels, there's a strong shift to the left in the activation curve and also in the inactivation curve, although it's important to note that in the systolic range, calcium release remains more or less constant. It's not impacted by the inactivation curve. So this sort of shift to the left in activation and greater diastolic channel activity has been associated with FKBP dissociation and phosphorylation. So we looked at those parameters. This is co-IP showing and Western blots showing FKBP associated with the ryanodine receptor, and there's clearly no difference between the wild type and the mutant. What's notable here is that there's only one FKBP band, which is FKBP12. 12.6 is known not to be associated with the ryanodine receptor in the mouse but no difference between the wild type and the mutant. And similarly with phosphorylation at the pKa site and the CAMK2 site, no difference between the wild type and the mutant in the average data or in the plots. The other parameter that's been associated with increased activity in CPV2 mutations is an increase in subconductance activity. And so that was what we looked at. These are 3 normal channels and 3 mutant channels. In both cases, the channels are opening from the closed level to the maximum open level. And both in the mutant and the wild type, you can see openings to levels that are less than the maximum conductance all the way through. And this is also shown in the amplitude frequency histograms. The black arrows here point to the maximum open conductance, the red arrows to the substate activity. Zero conductance is the closed level. So subconductance activity is not being induced by the mutation. So to summarize the first part of this talk, there's left shift in the calcium activation curve was expected. The inactivation shift was not expected, and neither was the fact that subconductance activity wasn't induced by the mutation. There was no decrease in FKBP12 and no excess phosphorylation. We were also a little surprised at the amount of subconductance opening in the wild type channels. This may be due to the lack of FKBP12.6 binding in the mouse. I'd like to spend a couple of minutes speculating on how the mutation might modify the channel. It's well known that prolines exert a strong influence on helical and beta sheet structures, whereas serine residues don't. So it makes sense that substituting a serine for a proline could cause some local structural change, perhaps negating some structural influence of the proline. So how is this transmitted to the distant channel pore? If we look at the high resolution structure of the RyR2 receptor, the 4 subunits in the side view between the transverse tubule and the sarcoplasmic reticulum membrane in this section, or a section through that area of the protein here. The 4 subunits are shown, or 3 subunits are shown. The 4th subunit is sitting behind. In this front subunit, the various domains of the subunit are color-coded, and the red dots point to all of the CPVT mutations that were known earlier this year and are shown in the priority paper. The residue, the mutated residue, is in helical domain 1, there and there. So local structural changes within this region are transmitted through the domain and through interdomain interactions into the adjacent central domain and C-terminal domain, and eventually impact on the channel pore of the S6 helix. This is speculation. It hasn't actually been shown for the cardiac RyR2 receptor or for any of these mutations. It hasn't been shown. It's been predicted, but it hasn't been shown experimentally. But such changes have been shown beautifully by Wallenbat-Pettigan earlier this year with the RYR1-MH mutation up here in the N-terminal domain, and it's very likely that similar changes are going to occur in the cardiac RyR2 receptor, and this will undoubtedly be shown shortly. So how does the pore change? This is an image of what the pore looks like in the closed situation and in the open situation. The closed pore isoleucine residues form the narrowest part of the channel, and they block the channel because the opening is only 1 angstrom in diameter. Ions can't get through. In the open situation, the helices rotate a little bit and move out, so that the narrowest part is then formed by this glutamine residue. And this is 3.6 angstroms, so it allows ion flow. So presumably what happens with our mutation is that there's a change in the C-terminal domain, which is directly connected to the S6 helix, which causes a similar movement in the helices. So I'll move on to the second part of the talk, which is about flecainide. Flecainide is used to reduce CPVT arrhythmia, but occasionally it can be pro-arrhythmic. Flecainide blocks sodium channels and it blocks the ryanodine receptor channel. We know that sodium channels can contribute to the arrhythmia in the CPVT mutation because the calcium leak through the ryanodine receptors is high. This increases the cytoplasmic calcium concentration and this reduces INA. Flecainide is anti-arrhythmic because it stops the leak through the ryanodine receptor, which then allows INA to recover somewhat. Conversely, in wild-type atria, flecainide is pro-arrhythmic, and this is likely to be because the cytoplasmic calcium is too low to affect the sodium current. So the effect of the drug is to reduce the sodium current, and this is pro-arrhythmic. Again, we wanted to know what flecainide does to the mutant channels. And what we expected to see, because it's been shown several times in the literature, is that there would be a voltage-dependent block of the channels. We didn't see that at all. This shows data plus or minus 40 millivolts, similar effect of no block, if anything, an increase in activity in both the wild type and the mutant channels. And this also appeared in our average data. This was a bit perplexing because it hadn't been previously reported. But when we looked at the conditions that we were using had not been used previously either. So our channels had a very low activity to start off with. And this was not in the presence of either ATP or magnesium. The only modulators of the channel that we were using was 1 micromolar cytoplasmic calcium, 1 millimolar luminal calcium. When we looked at the individual data, this emphasizes the lack of effect on lack of voltage effect. The circles show data at minus 40 millivolts, the triangles at plus 40 millivolts. And you can see the triangles and circles are mixed up throughout. What we did notice was that in the wild type particularly, high activity channels were not much affected by low concentrations of flecainide, but the open probability decreased at the higher concentrations. And channels that started off with a very low open probability increased in activity at low concentrations and didn't change so much at higher concentrations. This wasn't quite so apparent in the mutant data, but what we decided to do was to treat these two classes of high activity and low activity channels separately and see what happened. So these are the high control activity channels, and shown particularly in the wild type, the decline in activity as flecainide concentration increases up to 50 micromolar, and a similar effect in the mutant. So in the wild type, the open probability didn't change until 5 micromolar flecainide, and then it dropped. There was also a drop in the mean open time and an increase in the close time, with an overall decrease in the frequency of events. In the mutant, it wasn't quite so clear and perhaps a little bit messier, but a small decrease at high concentrations in P0 and small changes in the open and close time, and if anything, a small increase in frequency, but not nearly as clear as the wild type. These are the low control activity channels, and in both, a clear increase in activity at low flecainide concentrations in the wild type and throughout the range up to 50 micromolar in the mutant. No significant changes in open or closed times, but in both cases, there were small changes that caused an increase in frequency when the open probability increased. And more notable over the full range of flecainide concentrations in the mutant and the wild type. Okay, so how do we explain our data? What we're suggesting is that there is an activation site which is occupied with low flecainide concentration, which increases open probability, and a second site, again away from the channel pore, not voltage dependent, which inhibits P0 at higher concentrations. and that produces a decrease in cytoplasmic calcium concentration. It's anti-arrhythmic. These both exist with the channel blocking effect, which we didn't see under our conditions, but exists. And it's likely, this has been a bit of a conundrum because it actually blocks current flowing in that direction, but it in the cell reduces calcium efflux. So how does this happen? A recent paper by Bannister presents convincing arguments that what is happening is that in this case, flecainide is blocking the countercurrent flow, which prevents or reduces the flow of calcium from the cytoplasmic reticulum. So with subconductance activity, what we saw was unexpected. We saw that flecainide was increasing and stabilizing subconductance activity. This is shown in control records and in the frequency histograms, and also in the mutant. Significantly more subconductance activity than in the control. In this particular channel, again, the same thing, but in this case, we added ATP. And you can see that there's a significant increase. In fact, a lot of the activity was just stabilized. The subconductance activity, very little closed level, very little fully open level. Okay, so what's happening with subconductance activity? Clearly, the activity that we're seeing in all of these channels is intrinsic. It's not induced by anything, but it is stabilized by flecainide and by flecainide plus ATP. It's important to note that the substrate activity is not the substrate that's induced when flecainide blocks includes the pore. What structural changes underlie subconductance activity? And I'm not even going to speculate here. It's not known. It's an open question. It could be just a breakdown of channel gating, but in many cases, it appears to be organized. So it could reflect specific changes in the selectivity filter or in the channel gate. What would be lovely to see is data from cryo-EM of channels that are largely open to subconductance levels. And perhaps flecainide in the presence of ATP would be a good way to generate such channels. Okay, so the summary of this part, most of what we saw was unexpected. The high affinity activation site, lower affinity inhibition site, neither of which were voltage dependent, is certainly not conventional channel blocked by flecainide because of the lack of voltage dependence. And the fact that the subconductance activity is enhanced by flecainide, it's not induced by flecainide, it's not voltage dependent, therefore it's not pore block. The mutant channel activity is dominated by the effective activation more so than the wild type channel under these conditions. So our conclusion is that pore block and inhibition must dominate under most cellular conditions because flecainide inhibits ryanodine receptor activity and arrhythmia in humans and mouse models. Flecainide can activate the channels, and this may become apparent under some circumstances. And activation may contribute to the pro-arrhythmic effects that have been seen occasionally in patients and mice. And because of this, flecainide is contraindicated for use in structural heart disease. So the acknowledgements for grant support and infrastructure support from the John Curtin School and the University of Cambridge, various UK Cambridge Cardiovascular, British Heart Foundation, Wellcome, and Medical Research Council for grant support, and the Australian National Health and Medical Research Council, again, for grant support. And people contributing from the John Curtin School were Nicole Beard, Esther Gallant, Susie Pace, and Jane Stavala. And from Cambridge, I've already mentioned Sam, Chris, and James, and also Shiraz Ahmed and Haseb Bali. So thank you very much for listening.